So my name's Gemma. I'm one of the specialty doctors here at St James's, and I'm lead for acute oncology here at the Leeds Cancer Centre as well. Today I'm going to talk to you about the big 4 oncological emergencies. It's interactive, so if you are able to print out the handout that's on the VLE, you may well find that useful. If not, have pen and paper to hand because there's some activities during the presentation. So what I'm hoping you'll be able to get from this presentation is to be able to describe the big 4 oncological emergencies, recognise their importance, know how they may well present to you, and so this is not only in oncology but potentially in GP practice, in A&E, and outside in general medicine as well. Okay, and what I'm hoping that you'll be able to get from this presentation is how you initially manage this patient group. So the big 4 oncological emergencies are neutropenic sepsis, hypercalcaemia, metastatic spinal cord compression, and superior vena cava obstruction. And as I've mentioned, the learning objectives we will go through with each presentation. So for neutropenic sepsis, what I need you to be able to do is define neutropenic sepsis, identify the patients which may be at risk of developing neutropenic sepsis, be able to outline the management of that patient with suspected neutropenic sepsis, and be able to describe what constitutes a septic screen. So neutropenic sepsis is defined as someone who has a neutrophil count of less than 1 and who has symptoms or signs of infection or has a temperature of 38 degrees C or higher. Neutropenic sepsis can be more common with some of the high intensity chemotherapy regimes. So chemotherapy is given to target cancer cells, but it also affects the healthy cells, and that includes the bone marrow. And therefore that is the neutrophil count which will fall if it's affected by chemotherapy. The chemotherapy regimes which are by their nature more intense are the chemotherapy regimes which manage hematological malignancies, breast malignancies, and germ cell tumours. However, if you have any patient presenting who's on chemotherapy and they have worrying signs of infection, you may want to think about when they've had their chemotherapy and could they be neutropenic. Neutropenic sepsis has an overall mortality of about 5%, and so that's why it's important we pick it up early and we treat it early. Patients can decompensate quickly, so you might have a young patient who's on treatment for a germ cell tumour who comes in with a temperature, but their other parameters are okay because they're compensating for the infection, but then because they don't have the neutrophil count to mount the inflammatory response, they can decompensate really quite quickly and it can become life-threatening. So neutropenia typically occurs between 7 and 14 days during the chemotherapy cycle. However, it can be delayed or patients may well present a little earlier than this with low neutrophil counts. Therefore, working out the timing of the chemotherapy is key in your history of the presenting patient. As I've already mentioned, these patients may well present non-specifically unwell. They may have a high heart rate, they may have a relatively low blood pressure, they may or may not have a temperature when they present to yourself, especially if they've taken paracetamol. And what you need to also identify is, do they have any localising signs of infection? So what I'd like you to do now is pause the video, use the first page of your handout, which has a diagram of the person on, and I would like you to think of potential localising signs where a patient may present with infection. If you haven't been able to print your handout, please just jot it down on a piece of paper now, okay? And take a minute to do this, and then we'll discuss it in a bit more detail. So, it's really important that this patient group you do a top-to-toe assessment. So, are there any signs of a CNS infection? Does the patient have headache, visual disturbance, any neck stiffness? Some of our chemotherapy regimes mean that patients have very sore mouths, something called mucositis. So it's important to assess the oral cavity and see if there's any ulceration there or any signs of infection there. As you can see from the diagram here, our patients are at risk of respiratory tract infections, just as with the general population. So you want to be asking questions of, do they have any cough? Are they more short of breath? Do they have any chest discomfort? And then working your way down, our patients can often have their chemotherapy delivered through a central line. So ask the patient, do they have a PICC line in situ? Do they have a Hickman line? Do they have a portacath? It's important that you assess the area of insertion. Is there any redness? Is there any discharge? Is there any signs of infection there? Again, our patients, just as with the mucositis, can have irritation anywhere through the GI tract. And so does the patient have any diarrhea, any abdominal pain? Some of our patients may well have stents in situ to help with biliary drainage if there is a liver malignancy, or ureteric drainage if there's a problem with the peritoneum and that's causing ureteric obstruction. So it's important to ask the patient, have you had any procedures? Do you have any stents in situ? Someone with a biliary stent that has become infected may well present with rigors and right upper quadrant pain. Someone with a ureteric stent in situ who is developing infection from that may well have flank pain, dysuria, hematuria frequency. And then it's a generalised overview. Are there any rashes, any signs of cellulitis? Are there any bone pains? Do they have a catheter in situ? Are there any simple signs of a urinary tract infection? Okay. So I would hope that in the minute you had to think of where this person may have infection, you've been able to jot down head to toe the areas that these patients may find problematic. So then we come on to how you evaluate the patient. So as I've already mentioned, it's really important to work out the timing of the chemotherapy and what drugs were given. As a junior doctor, we wouldn't expect you to know what chemotherapy agents cause neutropenia in particular, but it is important when you're presenting to your colleagues that you present that the patient is on chemotherapy and when they started their last cycle. As I've mentioned, you want to know how that chemotherapy was delivered. Does the patient have any lines, or is it a tablet-based chemotherapy? Have they had any previous episodes of neutropenia? And as I've said, top-to-toe assessment, do they have any localising symptoms? As you would with any patient, it's then performing a physical examination with an ABC approach. What is their news score? Do you need to be thinking, I need to escalate this patient further? So do I need to be contacting outreach? Do I need to be contacting my senior because their patient is potentially hypotensive or tachycardic or looking like they might decompensate? And then in terms of microbiology, have they had any previous infections? Have we got any sensitivities on the system for that? Okay. Read your local guidelines, and when the patient's presenting, see whether they have had any recent resistant organisms. What constitutes a septic screen? So I'm sure you will have come across the Buffalo system that we use here in Leeds. Essentially, you need to be performing blood tests. So we want to do a full blood count. We want to know what the neutrophil count is doing. Is the patient anemic alongside that? What are the other inflammatory parameters? So what's their CRP? What's their lactate? Is the patient dehydrated? So what is their renal function? What are their LFTs doing? So again, for example, in a patient with a biliary stent, you would want to know, is their hepatic function normal or is it compromised? You then need to send off some blood cultures. So as we've mentioned lines with these patients, if a patient has a central line in situ, you need a blood culture from the line as well as peripheral, okay? Because that helps to determine whether the line is the focus of infection. And then what we tend to say is swab anything that has a discharge. So if you are worried about a cough, send off a sputum sample. If you're worried about a wound or a central line insertion site, send a swab off from there, okay? If there's any urinary symptoms, you need to dip the urine and send off a sample for MCNS. And again, if there's symptoms of diarrhea, sending off a stool sample is important earlier on. We tend to do chest x-rays in our patient population, and I think that's particularly important during the time of the coronavirus pandemic as well, because you want to know if there are any respiratory changes. And then what's incredibly important for patients presenting with potential febrile neutropenia is getting the antibiotics on board. So although we've talked in a lot of detail of how you're assessing this patient, NICE guidance and oncological guidance is these patients need prompt antibiotic treatment. So you need to assess their allergy status, have a cannula in situ and give them broad spectrum antibiotics within 1 hour, and that does save lives. Your ongoing management is then supportive, so IV fluids if they're hypotensive or tachycardic, a strict fluid balance so know what's going in and what's also being passed urine-wise. As we've mentioned, escalate if appropriate. So again, some of these patients may well be on curative treatment intent, curative chemotherapies, and it would be important to escalate that patient group if necessary. And discuss with your registrar. So even if you're not based in oncology, if a patient such as this presents to A&E, escalating to the oncology registrar on call is important so that we are aware of this patient and we can support you with their management. With these patients, sometimes the patient will be on palliative chemotherapy and may not want to spend a lot of time in hospital. So we err on the side of caution, treat these patients with antibiotics until proven they're not neutropenic, okay? And then we can consider stepping down their antibiotics in that situation. If a patient is neutropenic, the duration of the IV antibiotics depends on what we assess as their MAS score. So when the patient comes in, we assess what are their comorbidities, how well perfused are they, do they have any COPD, is the tumour type hematological or is it a solid tumour, what is their age, and together that combines into the MAS score, which can help us work out when we can de-escalate the antibiotics and get that patient home on oral antibiotics. Because as you can imagine, a patient who is potentially in their last few months of life would not want to be spending unnecessary time in hospital if we can get them home with oral antibiotics. But we need to do that safely, and that's why we develop these scoring systems. Another way that we support our patients is by giving GCSF. Okay, now this is a hematopoietic growth factor, and it helps with the stem cell proliferation. So as I've mentioned, chemotherapy targets cancer cells, but also affects the rapidly dividing marrow cells. GCSF shortens the duration of neutropenia. So it doesn't necessarily mean that a patient won't be neutropenic, but you would hope they'd be neutropenic for a shorter period of time and therefore reduce the risks of an infection during that period of time. It's not routinely prescribed at present, although it is prescribed with chemotherapy regimes where there is a higher risk of neutropenia, or if a patient had a previous episode of febrile neutropenia requiring a prolonged hospital admission. So what I hope you've got from that first part of the presentation is you're now able to define neutropenic sepsis, you're able to identify a patient group that would be at risk of developing neutropenic sepsis, you're able to outline the management of a patient who is presenting to you wherever that may be, and you're able to describe what constitutes a septic screen for a patient presenting with neutropenic sepsis. So now we'll move on to hypercalcemia. So hypercalcemia, what I would hope you'd get from this part of the presentation is be able to list the malignancies that this could be associated with, outline the pathophysiology of hypercalcemia and malignancy, describe how hypercalcemia may well present, and outline the treatment plan for this patient group. Again, I'd like you to utilise the handout if you've been able to print it out, or make notes if you're not able to print out. In pages 3 and 4 of your handout, there is a diagram that outlines normal calcium homeostasis. I would just like you to take a minute, so pause the video, and from memory be able to jot down what is the normal calcium homeostasis, and then we will go through that in a little bit more detail in a moment. What is normal calcium homeostasis? So, your thyroid gland recognises that you have a high blood calcium level. It then releases calcitonin, and that promotes the osteoblasts to deposit calcium within the bones. It also reduces absorption of calcium from the kidneys, and therefore your calcium blood levels fall. If you have a low blood calcium level, this is detected by the parathyroid, which releases PTH. That promotes osteoclasts to release calcium from the bones. It also stimulates the kidney to absorb calcium from the urine. The third thing it does is it converts the vitamin D to stimulate the bowel to absorb calcium, and therefore your calcium levels rise. So how does that alter in a person with an underlying malignancy? So there are two ways in malignancy whereby your calcium homeostasis is affected. The first way is the transforming growth factor alpha, so TGF alpha, and the second way is parathyroid hormone related peptides. Okay, and we will talk through these in more detail in a moment, but you can see from the slide this is how calcium homeostasis is affected. And when we go back to our normal calcium homeostasis, we can see the points in the flowchart whereby the PTH related peptide and the tumour growth factor alpha affects the secretion of PTH, and therefore means that there are uncontrolled rises in the calcium level. So which cancers is this most associated with? So cancers which affect the bones are an obvious focus of potential hypercalcemia. So non-small cell lung cancers, breast cancers, prostate cancers, renal cell carcinomas, and then the myelomas and lymphomas. The bone metastases themselves may cause hypercalcemia, or it may well be the PTH secreting tumour which is causing the hypercalcemia, such as in renal cell cancers. So I'd now like you to come back to your handout or to be able to make notes. And what I want you to do is, again, pause the video, take a minute and think about how these patients may well present to you, either in the general population, such as the GP practice and A&E, or on our acute oncology assessment unit if you were to have a placement with us. So if you pause your video now and take a moment. Hypercalcemia can present in very non-specific ways, and just as with the neutropenic septic patient, a top-to-toe assessment is warranted. The patient may present confused or drowsy or generally fatigued. They may have seizures if the calcium levels are particularly high. They may also have hyporeflexia or come to presenting unconscious. When you look at the cardiac symptoms, an ECG should be performed. These patients may well be bradycardic with a short QT interval, or they may have wide T waves with prolonged PR interval. The GI tract is a common way in which these patients present. So they may well have abdominal pain and constipation. They may well be vomiting or feeling nauseous. They may also describe that they have polyuria. These are all worrying symptoms for someone who has an underlying malignancy who may well be presenting to yourself. So how do we manage this patient group? If the calcium level is less than 3, the patient requires rehydration with IV fluids. If the calcium level is greater than 3 or they are particularly symptomatic, that is when we need to consider bisphosphonate treatment. However, it's really important that we rehydrate the patient before giving the bisphosphonate. And here in Leeds, the bisphosphonate we use is zoledronic acid, which is 4 milligrams IV after the patient has been rehydrated. Or if there is a fall in their renal function, we consider using permidronate. The other thing that we consider using, as you can see, is calcitonin, but that's only considered if the patient is particularly symptomatic or has tachyphylaxis. In the first instance, we would aim to manage this patient group with IV fluids and bisphosphonates. So we've now gone through the presentation of hypercalcemia. You should be able to describe the common malignancies that it's associated with. You should be able to outline the pathophysiology of hypercalcemia in malignancy. You should also be able to describe the range of presentations and your initial management plan for this patient group. So we now move on to metastatic spinal cord compression. And what I would hope you'd get from this part of the presentation is recognise the red flag symptoms for a patient that is presenting with metastatic cord compression or back pain, be able to list the common malignancies which spread to the bone and therefore put the patient at more risk of presentation with cord compression. And I would want you to be able to describe the initial management of someone who's presenting with cord compression. So I want you to now pause the video, have a think about what red flag symptoms you would worry about if a patient presented to you with back pain. So the red flag features for back pain are now up here. A patient that is less than 20 who has severe back pain, or a patient who is greater than 55, so the extremities of the age groups. A patient who presents with a history of trauma, if there is associated weight loss or associated temperatures or night sweats. If the patient is presenting with leg weakness or sensory loss of the lower limbs. If the patient has thoracic back pain, that's not a common area to have back pain. It tends to be more in the load-bearing lumbar region where patients present with back pain. So thoracic back pain itself is a red flag. If the pain is constant, or it wakes someone at night, or it's there at rest, and isn't controlled by analgesics, that's a red flag. If the patient describes urinary retention, or problems opening their bowels, or fecal incontinence, that is another red flag. And if the patient has, on examination, saddle anaesthesia or loss of anal tone, again, a red flag that you need to be considering in your differential is this metastatic spinal cord compression. So the image here shows spinal cord compression at T10. You can see that the vertebrae is affected by tumour and that the normal CSF, which is the white bit surrounding the spinal cord, is not evident where the arrow is pointing to T10. So spinal cord compression is the commonest neurological complication of cancer. It occurs in about 5% of cancers, the most common being breast, prostate, lung and haematological, just as when we've described with the hypercalcaemia patients. The mechanism may well be soft tissue infiltrating the spinal canal. It may well be compression of the vertebrae, again, if there's bony prominence within the spinal canal, or it may well be drop metastases, which are going into, again, the CSF space. So how do these patients present? So a patient who has a lesion which is above L1 will present with upper motor neuron signs. A patient with a lesion below L1 will present with cauda equina. And I'd like you to refresh your memories on what the symptoms of an upper motor neuron and a lower motor neuron lesion present as. 60% of this patient group will have pain. And if a patient is presenting with those red flags, they require an urgent MRI of their whole spine. You also need to inform the clinical oncology registrar on call. I would, if a patient has a known malignancy, inform the clinical oncology registrar at presentation. If the patient is coming via A&E and doesn't have a known malignancy, having the MRI whole spine may well be useful prior to contacting the oncology team. So this is the pathway which should be utilised for anybody presenting with potential metastatic spinal cord compression. They need 60 milligrams of dexamethasone with PPI cover, because if the tumour is causing compression within the spinal canal and there is edema around that, the dexamethasone can help with some of the decompression prior to intervention. That steroid treatment needs to be given whilst awaiting the MRI spine. If the MRI spine is positive for spinal cord compression, you need to consider, is this patient suitable for surgical intervention, or do we need to be speaking with the oncology team about radiotherapy? So how do we determine whether somebody may well be appropriate for surgical intervention? If the MRI spine shows a single area of vertebral collapse and cord compression with no other metastatic disease through the spine, then it may be that we could consider surgical decompression. If the patient has a good performance status, and if they're likely to survive greater than 3 months, again, we should be discussing this patient group with our surgical colleagues. And it's important that we investigate these patients early, because we can regain function more readily if we perform treatment within 48 hours. Okay. The surgery for these patients is extensive and has a long recovery period, and that's why it's important that you assess if the patient has a poor prognosis, would putting them through incredibly invasive surgery and the rehabilitation associated with that risk outweigh the benefits in the long term. If a patient has a number of areas affected, or their performance status is poor, or their prognosis is less than 3 months, then that's when we would consider palliative radiotherapy to improve motor function and symptoms. Okay. The side effect of radiotherapy, as you will have heard with some of the previous talks, can potentially be a flare in the pain that the patient's experiencing. They may well feel nausea, they may well have gut disturbance. And then the important thing after that treatment is rehabilitation. So what percentage of patients do you think will regain motor function after radiotherapy for metastatic spinal cord compression? So the reason that this is an oncological emergency and why we need prompt assessment and management is that 57% of patients will be able to walk again if they are given prompt treatment within the first 48 hours. If motor function is lost for a longer period of time than that, then it's less likely we'll be able to recover a good functional status for this patient group. So in that brief overview of spinal cord compression, I would now hope you'd be able to recognise the red flag features for someone presenting with back pain, be able to list the common malignancies which can spread to the bone, and describe the management of someone presenting with metastatic spinal cord compression. So our final oncological emergency is superior vena cava obstruction. What I would want for you to be able to do after this presentation is describe what superior vena cava obstruction is, recognise how it presents, list the malignant causes of SVCO, but also be aware of the non-malignant causes, and know again what the initial treatment and management of this patient group is. Someone presenting with SVCO may well present breathless, they may have a headache, they may well describe neck, arm or facial swelling, they will potentially have collateral veins across their chest wall, they may look cyanosed, and they may describe some visual disturbance. And the reason for that is if you have a tumour that is compressing the central mediastinum and the SVC, that restricts the blood flow, the blood return from the upper limbs and from the head. Case study. Mrs. R is a 63-year-old ex-smoker who presented to the acute assessment unit with a 2-month history of gradually increasing shortness of breath. Over the last 2 weeks, her breathing has got worse. She describes a fullness of her face and her neck, and she describes some veins that have appeared across her chest. She's been losing weight recently and has some difficulty now with her swallowing. When you examine her, there's distended neck veins, her chest and her lips are blue. Clinically, she has signs of SVCO. Blood tests have all been sent, but what would be your initial investigation of choice? So you perform an X-ray for this lady. You can see from the X-ray she's got changes in the right lung field and she has widened mediastinum. What would be your next investigation of choice? So you would want a high resolution CT or a CT with contrast. And this CT scan shows the tumour both in the periphery of the right lung but also centrally. And it's the central tumour which is causing the symptoms and the signs of SVCO. And the reason that we perform those investigations is the management depends upon is the compression from an external cause or is it intrinsic with a thrombus. And so here we've listed the causes of SVCO. Now the malignant causes are, as you would anticipate, tumours which affect the mediastinum and the central chest. So lung cancers, lymphomas, germ cell tumours, thymomas, esophageal cancers, or potentially a thrombus caused by the hypercoagulability of a patient that has an underlying diagnosis of malignancy. It's really important not to focus just on the malignant causes because you may well come across a patient that is presenting in the community that may not have a malignant cause for their SVCO. So I've also listed here some benign causes. So a non-malignant tumour such as a goiter, a patient presenting with mediastinal fibrosis, post-radiotherapy changes, infection or TB, a large aortic aneurysm can present in this way, or a patient that has a central venous catheter for another reason potentially could have scarring and SVC constriction from that. So how do you treat this patient group? Again, our treatment is based around steroids. So potentially whilst you're awaiting the CT thorax, you would give 60 milligrams of dexamethasone with PPI cover. And then dependent upon the cause would depend upon your treatment moving forwards. So if there is external compression and the patient is decompromised, you would potentially look at putting in a vascular stent. The patient may require radiotherapy or chemotherapy if the suspicion is that this is a cancer which would respond quite quickly to either of those treatments. And if the cause is due to a thrombus, you want to anticoagulate that patient, so commence them on low molecular weight heparin. This X-ray is shown after 2 cycles of palliative chemotherapy how much the tumour has shrunk and therefore how much better the patient is both symptomatically and prognosis-wise. So I would hope you'd now be able to describe what superior vena cava obstruction is, recognise how it presents, list the causes, both malignant and non-malignant, of SVCO, and know your initial treatment and investigations for that patient. So thank you for listening to this presentation. What I hope you will get from it, as I've mentioned, is febrile neutropenia, do not delay giving antibiotics, hypercalcaemia, always check the calcium level, rehydrate the patient and consider bisphosphonates. Spinal cord compression, if you suspect it, you need to give steroids with PPI cover and arrange urgent imaging and discussion with the clinical oncology and surgical teams. And superior vena cava obstruction, again, if this is suspected, steroids with PPI cover, investigations promptly and referral to the correct team dependent upon the investigation outcome. There's some further resources here to guide your reading, and thank you.